Yes.
Good afternoon, everyone. Welcome to the May 26th Provider and Community Forum held by the Department of Disability Services. I am Winslow Woodland, Deputy Director for the Developmental Disabilities Administration, and I'm sitting in for Director Andrew Reese today, who's not with us today. Um, what we would like to do is to start off sharing our COVID data for the month of May. And just wait a second for the PowerPoint to come up. So if you were here last month, we didn't have any cases to report in the month of April. We remained steady at 808. We had one new case reported. And so for the month of May, we have one new case, and that case was in a natural home. And so the breakdown has only changed by one for natural homes. And that person did not require hospitalization. And interestingly, the case was someone who was asymptomatic and who happened to just give themselves a test and find out that they were, in fact, COVID positive. So a word to the wise is that we still need to be vigilant and aware. And the breakdown for the cases is as follows. Host home, we have 24. The intermediate care facilities, we have 153. Mental health facilities, we have 1. Natural homes went up, as I stated, by 1. So we have 181. Residential rehabilitation settings, we have 62. In nursing homes, we have 2. In supported living, we have 378. And out-of-state placement, correctional facilities, we have 1. And out-of-state placements, we have 7. And that's the only change, is the one case to the other data as well. Today we have a rather small agenda. We have 3 presenters today. And here you see the hospitalizations. That hasn't changed. And we have no updated data on confirmed deaths from COVID. So there are people who have died but not have COVID as the cause of their death. And as stated, we have 3 presenters today. We have the Department of Behavioral Health, we have the Department of Healthcare Finance, and we have a provider. And so for our first presenter today, I believe, is Ms. Garvin here, Charlisa? I'm sorry, Ms. Barnes. I called her by her maiden name. You know people a long time. I actually called you by your maiden name. So Rhonda Barnes is here from the Department of Behavioral Health. On our last call, we had questions because May is Mental Health Awareness Month. And so we thought it best to bring on one of our partners who we collaborate with for people who we support who also use services from the department, to give you a brief overview on services provided by the Department of Behavioral Health. So Ms. Garvin Barnes, take it away.
Okay, Mrs. Barnes. Hi, good afternoon. Let me turn on my camera. Hopefully I have. Thank you for having me. Does anyone have my slides? Sorry, okay, thank you. Good morning. Thank you for having me, and I'm here to do a very brief presentation on DDS and DDA and DBH collaboration. Next slide, please. Okay, so the scope of mental health treatment and services provided to individuals with intellectual and developmental disabilities are the same as those provided to any citizen of the District of Columbia. So there is no difference in service provision. Individuals with intellectual disabilities and their family members can obtain services through contacting our Access Helpline, which is telephone number 1-888-7-WE-HELP to get connected to DVH services and linked to a core service agency. Individuals who have guardians or surrogate decision makers will need to have that person on the call to complete the enrollment. DBH also has a specialty program that is geared towards serving only individuals with intellectual and developmental disabilities who have a co-occurring mental health diagnoses. And that program operates out of 35K, where I serve as the Deputy Director for the Behavioral Health Services Division. That program has been in existence for close to 30 years. And we currently are serving 175 consumers, which 173 are linked to DDS DDA. Additionally, on a bi-monthly basis, key personnel from DDS, DDA, and DBH meet to collaborate on shared issues and concerns. Additionally, as needs present, the agency personnel may engage in integrated care team meetings to address the needs of consumers who are high utilizers of our services. So there has been an ongoing collaboration. There is no barriers to treatment, and that if a barrier to treatment does present, I recommend that individuals reach out to me. I will put my name and number in the chat as well as my email address to see whether we can address those issues and clear up any concerns that you may have. I can say from a historical perspective that I've been involved with both agencies. I started work with what was then called MRDDA in 2003 and served in an integral role in trying to ensure that the services were streamlined and service provision was ensured for the individuals that were served back during that time, and have continued the efforts towards ensuring service delivery from a mental health perspective in my current role and position at DBH. Any questions?
If anyone has any questions, they can type them in the chat. And right now, I don't see any.
Okay.
Can you talk about treatment? What treatment is being offered?
Okay, in terms of treatment, psychiatry, community support, counseling, all of the services that are offered under our MHRS, mental health rehabilitation services. So diagnostic assessment, we have ACT services, assertive community treatment. Additionally, freestanding mental health services are also under the auspices of the Department of Behavioral Health. So individuals who may not want community support and just want medication and or counseling can go to one of our freestanding mental health clinics in the area.
And we have a question. Can we understand more about the specialty program for people with ID at 35K?
Okay. So the specialty clinic at 35K, we currently serve 175 individuals, as I indicated. We have a full-time psychiatrist, two mental health specialists, one social worker, and a psychiatric nurse assigned to the program. We provide all of the MHRS services, inclusive of diagnostic assessment, med-somatic services, community support, as well as counseling. We are available Monday through Friday, 8:30 a.m. to 5:00 p.m. The enrollment process had been halted, but if you reach out to me, we are accepting a few cases at a time. since the pandemic emergency has ended. So again, my name is Rhonda Barnes. I facilitate, I wear many hats. So I also facilitate the intake process for the program. So if you call me directly, 202-442-4921, or reach out to me at Rhonda, RHONDA.barnes@dc.gov. We can discuss the cases on an individual basis and determine whether the intake process. What we look for is that the individual does have a diagnosis of intellectual disability, but we're not as stringent as DDS in terms of requirements. Someone can come and say, like, I can give an example of yesterday. There was a consumer who came in through our urgent care clinic. His brother brought him in because he was having some challenges. His brother indicated that he was an individual with intellectual disabilities, but he's not been able to gather any of his paperwork. This gentleman is in his late 50s, early 60s. And so whatever paperwork was there to identify his pre-18 diagnosis was not present, but he is in need of mental health services as well. So taking his brother at face value, I am going to be reaching out to him on Tuesday and scheduling an intake through our program at 35K.
And we have another question that is, could you share whether there are DBH providers that specialize in supporting people with developmental disabilities?
They are not, we are the specialty, but there are individuals who are working with the population throughout the DBH network of care. They have been supported in learning and understanding how to work best through the collaborative process that exists between DDS and DBH. There's been a series of trainings for behavior support. There are technical assistance that can be provided through both agencies. And so there's not, we're the one, it's at 35K, there's only one specialty, but there are supports given to the other DBH core service agencies in terms of serving the population.
There is another question. Are there freestanding mental health clinics the same as core service agencies?
No. The freestanding mental health clinics are psychiatric driven. They're psychiatrist driven. So they do not have the full breadth of services that a core service agency must provide per regulation. So the freestanding clinics, they have a psychiatrist, they may have social workers provide counseling services, but beyond that, they do not provide community support.
And what are the eligibility requirements?
Or ACT team services.
Okay, thank you. What are the eligibility requirements for DBH services? Is it the same or different eligibility for the 35K program?
The eligibility criteria is the same. You just have to have a persistent or pervasive mental health diagnosis. So there's no other difference. The difference for our program is that we specialize and we only, except for the 35K program specializing with individuals with intellectual and developmental disabilities, is that they have to have a co-occurring diagnosis.
And do you have to be eligible for Medicaid to receive any services from DBH?
Yes, Medicaid eligibility is a requirement. There are some core service agencies that do accept Medicare as well as private insurance, but it's according to what they're, if they're paneled with a private insurer. And we also accept MCOs, managed care organizations.
And I'd like to just thank you for coming and joining us today, as well as to share with the group that the Department on Disability Services, as well as DBH, we meet on a monthly basis, and our psychologists here, which we have two, work closely with team members at DBH on cases where we are called in to do so. And also, I should also add that there are people who we support at DDS who also receive services from DBH, and they choose not to share that information with us, and it is their right to do so. There's another question. Can you explain your ACT team support? And I'm guessing that question is a general explanation of what ACT actually is.
Okay, so ACT is an intensive program where the whole goal is to keep someone out of the hospital or keep them out of the criminal justice system. ACT teams are supposed to, per regulations, reach out to their individual in care and provide services out in the community on an intensive basis. I can best describe it as a wraparound support in terms of going out into the community, acting upon crisis, and helping that person reach a level of stability where they're not going in and out of the hospital on a frequent basis, or intersecting with police or the criminal justice system. A person can be in the ACT team for several months, up to a year, but the goal is to try to get them back to a level of homeostasis as quickly as possible. So it is an intensive support. It's our highest level of care beyond hospitalization.
Well, Ms. Barnes, I want to, just as I think know exactly my question, explain how we acquire
your ACT services. Okay, so ACT is a level of care, and so when someone is in a outpatient service, the team will look and assess that person to determine, okay, you're at CPEP every other day. You've spent some time at PIW, you've had some police involvement, and we're no longer using the locus, but you would have done what is called a level of care utilization review and determine, based on that information, that their score indicated that ACT services were necessary. And so then that clinical team would make a referral for ACT services. That referral would be reviewed, and then an ACT team would be assigned to that individual, or that individual, which we would select an ACT team with that individual, because everything is consumer choice. Now, a consumer can elect not to receive ACT services because, again, it is their right. So we would present the information, encourage as much as possible, and based on informed consent, that consumer can say, no, I don't want ACT services.
All right. The question is CPEP still operating? The answer is yes. And do DBH and DDS connect on folks who go to CPEP often? And I can answer that question. Yes, we do. And anytime someone uses CPEP, and they are supported by a provider agency, that is entered into our incident management system, as well as during our collaboration calls with DBH. We have discussions on people who utilize those services more frequently than we believe is a reasonable amount of visits. In other words, we don't believe CPEP is the guiding goal for persons supported within the community. However, many times that's the absolute only service that can support that person becoming stable. So we do talk about those cases, and in many cases we get calls directly when people are at CPEP, as well as our providers work with the staff at CPEP as well. And also does DBH specialty program do telehealth support?
Yes, we do telehealth support. That is
And,
something we have been utilizing during the pandemic. But we are now encouraging as much as possible consumers to come into the office.
and another question is, if you don't use Locus now, what are you using?
We are moving towards, as a department, using the DLA 20 as our functional assessment tool. And so everyone is in the process of being trained and certified in utilizing that tool. And that tool, the folks under my supervision who have been trained as train the trainer to train folks on how to use that tool have indicated that that tool is more comprehensive and does take into effect individuals with intellectual and developmental disabilities into determining their functional levels.
And is there a cap on the number of people who can access the 35K Street program?
There is a cap based on the number of workers that I do have. They do have very high caseloads currently. And so what we have been doing in the past is, as people moved on, whether it be nursing home, I hate to say death, or deciding that the family has decided to move them out of the area, or however they decide to move on from our services, then we do a one-to-one replacement.
Well, again, Ms. Barnes, I want to thank you for taking your time out and presenting to us today and answering our questions. I can't say we won't have you back, because this was very informative, and I think based on the questions, they definitely, there is a need to move on. And there's another question, hold on.
Okay.
Is DDS still responsible for completing incident reports for people supported under DBH when the incident occurs during a time when they are supported under DBH? And so that's a very good question. And my answer is, anyone that is supported by DDS that has an incident, as by definition what we are according to our policy, absolutely. We if a person's being supported under DBH, which I'm not certain what that would mean, even when people are hospitalized at St. Elizabeth and we're made aware of incidents that occur, we do want that information reported to us. Now, whether we investigate it is another matter, but we want to be aware of any and all incidents that occur related to the people that we support. Does not mean we will be investigating those incidents, but we definitely want all incidents reported to us. That's a great question. Thank you.
And that was a great question. And I can say from the DDH standpoint, whenever we are alerted or become aware of an incident, and we will communicate that through service coordination of what our concerns may be. And we will also specifically to death investigations, we will enter that into our incident management system for those consumers that we care for, because we have to make that report. And we will work with DDS, to get whatever information we need to provide in terms of our reports that we have to complete.
And we have another question. Does your program support youth?
We are adult serving, so 18 and above.
All right. Rhonda and Winslow, I appreciate you discussing this topic during today's community forum. Mental health is so important, especially in the wake of COVID. Mental health supports are crucial, and I hope we can continue this conversation. Happy Mental Health Awareness Month, exclamation point. Thank you, Allison, for that kind comment and overview. And with that, I again would like to thank you, Ms. Barnes, and
Thank you.
We appreciate you coming, and we can move into our next presenter.
All right. Thank you. Bye. Bye-bye.
Thank you. Okay, so I'd like to present, I'd like to welcome the Department of Healthcare Finance, and we have Kayla Hagans.
Hey, great day, everybody. Shalise, I'm ready when you're ready. I apologize. 1 second.
No worries. Thank you. All right. Thank you, Shalisa. So great afternoon, everyone. My name is Kayla Hagans. I'm a management analyst within the Department of Healthcare Finances, Division of Eligibility Policy. So today I will share the latest information on what has been happening around DC Medicaid and renewals. Go to the next slide. All right. So Medicaid beneficiaries will have to renew their coverage for the first time in 3 years. So in March of 2020, CMS temporarily waived the need to renew Medicaid coverage, and states received a 6.2 financial boost to accommodate the increased enrollment. Medicaid enrollment has increased about 20% since the start of the public health emergency, and we now have over 300 district residents enrolled in Medicaid. At the end of 2022, Congress passed legislation ending the continuous enrollment requirement that went into effect on March the 31st, 2023. Therefore, the district was required to restart Medicaid eligibility renewals effective April the 1st. Now, as a side note, we started Alliance and Immigrant Children's Program, or ICP, renewals in July of 2022. Next slide. All right, so passive renewals and renewal mailing timelines. So the district is comprised of 2 Medicaid groups. We have our MAGI groups and we have our non-MAGI groups. In our MAGI groups, the Medicaid beneficiaries consist of adults 21 to 64, pregnant individuals, children or youth 0 to 20, and then our parent caretaker relatives. Now, some beneficiaries may be passively renewed and do not require completion of a renewal packet. Passive renewals are automatic renewals that leverage electronic data sources about 65 days prior to the end of the renewal certification period, and they require no further action from the beneficiary. If successful, the beneficiary is sent an approval notice informing them of their new certification period. This process occurs at the end of the month prior to the mailing of the renewal packet. Now, if the beneficiary was not able to passively renew, for the MAGI group, the renewal notice is sent 60 days prior to the certification end date. If the renewal is not received, or there is an outstanding verification, a notice of pending termination is sent 30 days prior to the end of the certification. Now, our second group is our non-MAGI Medicaid beneficiaries, and they consist of individuals who are aged, which is 65 or older, blind or disabled, and a long-term care or waiver participant, or they are in the qualified Medicare beneficiary group. These individuals are sent renewal notices 90 days prior to the certification end date. Again, if the renewal is not received or there are outstanding verifications, a notice of pending termination is sent 30 days prior to the certification end date. And then for the next couple of slides, I'm going to show kind of what the Medicaid renewal packages may look like in the mail, and then some sample notices. And again, just for reference, MAGI stands for Modified Adjusted Gross Income. It's just a formulation of how we tabulate income for those beneficiaries. So we use tax information for MAGI, and then for non-MAGI, it's more of verification of income. It's a little bit different. You can go to the next slide, Shalisa. All right, so Medicaid renewals will have distinct markings. Beneficiaries should look out for this green line on their envelopes. This is a distinctive marking to let them know that this is an important document and it contains their renewal. We could do the next slide. All right, district direct sample notices are online. We have a few different renewal notices. In this example, you will see our non-Magi notice for our age, blind, disabled groups. That's on the left top hand. In the middle is our D2 renewal notice, which we use for our Magi groups. And on the right-hand side is our long-term care renewal notices. However, please note that most of our renewal forms will be comprised of the conversion renewal, which is a lengthier form. We have a new eligibility system, and the conversion renewal contains all important information that we would need to update the case. Please note, after the first year of these renewals, beneficiaries will receive the shorter form. All right, next slide. All right, renewal grace period to reinstate benefits. So beneficiaries are given a 90-day grace period to renew Medicaid if they did not complete their renewal prior to their certification end date. So for example, if they were a June renewal, they'll have until September the 30th of 2023 to get their renewal in. This grace period allows additional time for individuals who fail to recertify timely. If the beneficiary is determined eligible for continued coverage, coverage will retroactively go back to the beginning of the certification period. So the example I have is if a beneficiary certification ends June 30th, they turn in their renewal packet on August the 3rd. If they're deemed still eligible, benefits will be reinstated back to July 1st, 2023. Individuals attempting to recertify their coverage after the 90-day grace period following their certification end date will have to be required to submit a new application. So for instance, if the grace period for June renewals ends September the 30th, any application received from October the 1st on forward will be considered a new application. All right, next slide. So the completed renewal form packet. So the completed packet contains carefully reviewed answers to all questions on the renewal form, the long-term care supplement form, and an updated LOC. We should have a signature, whether it be wet, which means just ink, electronic, or telephonic, and then a submission of any current documentation of income and DC residency. All right. So current income must be verified at renewal. So this is just a couple examples of different documents that we use to verify income. It could be pay stubs, a retirement or disability statement. It can be received via paper, electronic, or telephonic, an employer verification form, and it could also be a written statement if there's some type of discrepancy that needs to be explained, or if that's the only viable way to verify the income. All right. So renewal must also verify DC residency. And so this is an example of some of the residency documentation we could use. It can be an active lease agreement, a phone or utility bill that's been within the last 2 months, a DC voter registration card, something from DMV, utility bills, and then there's a couple of other examples here. And I'll make sure to share the slide after the meeting. All right. The DHCF website contains useful information to renew coverage and share with beneficiaries. So the DHCF website now includes key information and messaging on Medicaid renewals. So we encourage beneficiaries to update their contact information, educate beneficiaries on how to use District Direct, which is our eligibility system, We have a sample of renewal forms, and we also have a stakeholder communications toolkit. And this is the website, dhcf.dc.gov/Medicaid renewal, which I will also share in the chat after the presentation. We can go to the next slide, Lisa. All right, so again, we're doing outreach to beneficiaries, and it's more just a letter in the mail. So we're doing District Direct. So beneficiaries may log into District Direct. They can see notices, upcoming renewals, and take any type of appropriate action. We'll be doing text messaging, robocalls. We've also done some citywide advertising and outreach on bus, radio, and through key partnerships. One of the things that we're trying to get out and want our beneficiaries to be aware of is scams. So in other states, Medicaid programs have noted instances of some fraud through emails and texts. So just note the district will never charge money for Medicaid renewals or ask beneficiaries to visit a website that is not a dc.gov account. Dedicated outreach to special populations. So we are doing dedicated outreach to our senior beneficiaries. We've been partnering with DACL to train their staff and senior service network on the renewal process. Seniors will then be able to access in-person assistance at senior wellness centers and other community dining sites across the district. The Deaf and Hard of Hearing Senior Center and Senior Center for the Blind have also committed to assisting seniors with applications. We're training employees at DDS and their providers to help beneficiaries. We're also meeting with outreach staff like shelter caseworkers and adult daycare centers that work with beneficiaries experiencing homelessness, just to ensure that they're prepared to spread the word and assist with them completing their renewals. Again, additional outreach that we're doing for beneficiaries. We will send renewal packets again to any beneficiary who can't passively renew their coverage. We will be texting the cell phone numbers of beneficiaries to ask them to update their address and or complete their renewal packet. Conducting automatic phone calls. We're also increasing our staff at the Public Benefits Health Call Center to be able to assist with questions and concerns. We're also increasing our staff at the DHS Service Center to be able to process more applications, and doing different training groups such as this one to notify everybody on how to update contact information and renew Medicaid. All right, so what can some stakeholders do and say to beneficiaries? So our main message has been don't wait to update, and then to check the mail for important information. So one of the key targets is just to make sure that beneficiaries have up-to-date contact information. And then we're promoting them to go to our website at districtdirect.dc.gov to be able to update their contact information, see when their renewal is due, and that type of situation. And then we also want them to make sure they're checking their mail, to be looking out for any letters about Medicaid, Alliance, or ICP coverage, because this letter would let them know it's time to complete their renewal. And again, to look for that distinctive green mark. So this is the website. Again, I will also put that in the chat once I finish the presentation. So this is just an example of some of the advertisement that is circulating through the district and that you might have probably seen on any of the local buses or different articles and whatnot. So just wanted to share this. So if you see these type of these colors, these figures, as they're more of a cartoon figure, just to know that this is all related to DC Medicaid, and just encouraging beneficiaries to make sure their contact information is up to date and to look for their renewals. All right, and these are just some methods in which a beneficiary can submit their renewal packet. We're encouraging, of course, that they do it online via districtdirect.dc.gov. They can also submit it by phone, mail, or at the drop-off service center, and then they can also submit it via fax. All right, and then lastly, we have been working to keep the website page up to date in terms of our renewal process. And this again is our website address, the dhcf.dc.gov/Medicaid renewal. We have some frequently asked questions on there that we've derived from different stakeholder meetings and different questions that we've received. There also are training videos on the website on how to log into District Direct, how to change your address, and do a couple of other things in the system. And then we also do a community meeting that is bi-weekly. And to get more information from that, you just could email medicaid.restart@dc.gov, which I will also put in the chat. And there also have recordings of previous meetings that we've had in the community and whatnot. And so just the last thing we want to just make sure is that the beneficiaries are on alert, and just to make sure just to watch out for any type of Medicaid fraud related to Medicaid renewals. And they could always call our call center if there's any questions about maybe something that they got in the mail or a phone call or text that they may have received. Okay. So that concludes my presentation. Any questions or feedback?
Thank you, Ms. Hagan, for that very comprehensive presentation. We do have some items that are in the chat, and I'm going to ask that if anything that we responded to, because some of the questions DDA staff have responded to, and anything that you hear that's incorrect, if you could just kind of pull us back into reality. So the first is regarding Medicaid recertification. See my latest blog post at https://www.ddnwdc.com. Again, that's https://www.dd. Oh God, can somebody read that? My glasses are really not. Wait a minute. Hold on. Okay, I'm sorry. I got it now. I figured out how to make it bigger so I could see. It's DDNWDC. DDINWDC. So DDINWDC.com. All right, and this is recorded, so it's www.ddinwdc.com, and that's from Carl Grigsby. And next, Allison, to everyone, did I get the enrollment number right? 300,000 district residents are enrolled in Medicaid, which is roughly 43% of the population. And Allison, data that was before me, states that 292,727 DC residents are covered by Medicaid/CHIP as of December 2022. And so also the question is, MAGI is modified adjusted gross income. So the question was, please say again what MAGI stands for. And MAGI is modified adjusted gross income. And then we also had, before the pandemic, pause in renewals. How often was recertification happening for people supported by DDS/DDA? Who was handling these recertifications? And we have a team member, Renitris Parker, who responded DDS waiver unit completes Medicaid renewals for all persons enrolled in the IDD IFS waiver. Persons who are not enrolled in waiver must renew their own Medicaid, and ICF providers are responsible for completing Medicaid renewals for persons in their facility. And I would also say that we expect providers to help people's who need support in renewing their Medicaid as well. And then we have the contact information for the Medicaid waiver renewal. That would be Pamela Harmon, and that's pamela.harmon@dc.gov. Ms. Harmon is the program manager of the Medicaid waiver unit. And also added is that Medicaid renewals are due annually, and their renewal will depend on when they were enrolled into the waiver services for their initial waiver. However, renewals are aligned with the person's ISP effective dates. So essentially, prior to, I believe, like 4 years ago, renewals and ISP dates did not align. We found that to be inefficient, and we worked tirelessly with DHCF to ensure that ISP effective dates were aligned with the waiver renewal dates. And waiver residential providers are responsible for assisting providing persons supported with current financial information, i.e. pay stubs, bank statements for Medicaid research. So there's a dual amount of support going there. And hopefully I covered everything. If there is, okay. Okay, also B. Parker and other DDA agencies providing residential supports, not just ICF, have been told that they are responsible for filling out the forms. This is confusing. So the waiver residential providers are responsible for assisting with the payroll data and the income data.
But if Carol has some specific examples of that, we'd like to hear that, because I've not heard that in the past.
And I don't know, Carol, can you come off mute, or is she able to come off mute?
Yeah.
I'm off mute. Actually, this was the question that I asked you, Winslow, a couple of weeks ago. And
right. And
yeah,
my answer,
okay. And the answer was that provider agencies are responsible in the case of residential supports. That seems to differ from this information.
So to be clear, our expectation that providers support people as if we weren't there. So by we, I mean in family members and or the Department on Disability Services. So when I say providers are there to support people, that's what I mean. So if you're asking, do we have a hand in the research? We absolutely do. So when I give the statement that providers are responsible, it's my expectation that in all aspects of people's lives, that we pay providers to support people in their lives. So when I make that statement, if you want the nuts and bolts about who fills out forms, we absolutely have providers that help people fill out forms. So I'm sorry if I was confusing.
Well, to be clear, I'm still quite confused. And I doubt that I'm the only one, because the forms have been received in the agency, and they do understand they are supposed to be filling it out thoroughly.
So Carol, that's my question. Which, do you have examples of names of agencies?
Well, yeah, I mean, I think we can take that offline, but I don't really think I should get into all of the particulars in a call like this, but we can take that offline. But again, I mean, I am one family member with questions. I've heard other people with questions. So I just think there is sort of a lack of clarity, and it's gray when it needs to be black and white.
Yeah. Nothing has changed with respect to the process, pre-pandemic. There's been a portal change. The mechanism used to enter the recertification applications has changed, but the responsibility for the different entities or people who actually upload or submit the application materials remains the same. So, Carol, if you could email.
Personally, Jared, on our particular case, but I really want to underscore, I'm not going to be the only one with questions, and I'm not the only one with questions.
Sure.
And even what I'm hearing on this call differs from what I've heard elsewhere. So I just really think that this is a little too blurry.
I'm sorry, I didn't hear the last part. You broke up.
I said, I just think that this is too blurry, and I'm not the only one with questions.
Yeah, and I definitely appreciate your questions because they help us understand so much overall relative to when we believe that things are running smoothly, and if there are people who are confused or who, for whatever reason, are not able to get their renewals done. To Jared's point, like nothing has really changed in terms of this process, and we pride ourselves on keeping people able to receive the benefit that we're talking lots of money that is provided in terms of services, and we're talking about lots of people, a little less than 2,000 people who rely on us ensuring that this benefit is there. And we don't think we're perfect or near perfect, but trust me, we definitely want to know about these individual cases. And I also would just like to take this opportunity just to say that these forms are great for general questions, but when there is a problem, to the extent that people believe that is a systemic problem, this is probably not the best place to solve those. And if people have information, it shouldn't be a monthly form or bi-weekly call. Like, I'm in my office just about every day, and my number is 202-730-1618, and I'll make sure I put it in the chat. But if people are experiencing confusion or challenges, we'd like to know about it, because we don't always publicize it, but there are many people who tell us how great we're doing, and also who are not experiencing quote unquote confusion or challenges relative to this issue. But when there's one, we know we have a problem. So we definitely will take any questions, and I'm going to put my information in the chat for anyone who is confused or who doesn't understand, and we'll make sure that we do the best that we can to ensure that they are, aware of what's happening.
There was another issue that before Kayla jumps off, I just want to confirm, Kayla, that a few of us participated in a meeting earlier today where there was a question about whether stimulus payments, also known, I think, as economic impact payments, counted toward income. And I know that, well, I don't know this, but I think during the pandemic, there were conflicting instructions or guidance that had come out, but I believe that the answer is that those stimulus monies do not count as income, but hoping that you could confirm or ask someone to confirm that for us.
Sure. Let me take that back. I think I know what it is, but I just want to make sure too, and I can send up a follow-up email in writing. No worries.
Okay. Thank you very much.
Sure.
Okay, just typing in my contact information before I move back to the chat and see if there are. Can't type today. Bear with me, folks. I think I used to be able to type really fast. Okay, so let's see. Let me go back to, okay, we have, let's see, notifications. Oh, notifications are emailed to providers 60 days in advance of the medication recertification. And Kayla has posted in the chat DCHCF Medicaid renewal information page, and that's https://dhcf.dc.gov/Medicaid-renewal. All right, https://dhcf.dc.gov/Medicaid-renewal. Thank you, Kayla, for that. And there are also Medicaid community meetings. You can email medicaid.renewal@dc.gov, and there, I believe that will get you the invite to those meetings. And I believe it's also on the DACF web page that the invite and dates and times of those meetings are there. All righty. Well, thank you very much, Kayla, for that presentation. We're so glad to have you, and thank you for all your hard work on this. And if there are no further questions, we'll move into, we have Dr. Charlene Smith, who is with We Care, and there was some discussion on mental health, and we felt it necessary to have a provider talk about what they actually do to support their team members. Anyone who's worked in this business may be aware this business can be, a labor of love and at times very stressful. So Dr. Smith, if you take it away.
Yes, good afternoon. Thank you, everyone. And thank you for the opportunity to present from the provider community. And for me, I take to heart because I started out as a DSP when I initially came into the field. Of course, we know as a DSP is different from any other job, career field we would ever have. It's hard work, it's emotionally draining, and we have to put a lot. We must be selfless. We have to have thick skin. Sometimes we're dealing with people who have clinical and medical complex diagnosis and some with behavior support plans. Where as a direct support professional, you're dealing with someone spitting at you, cursing at you, just saying and doing all types of things. And you have to be in a posture to receive it and not take it personally. You're also making sure that you're assisting with their health and their safety. I'm sorry.
Can we ask that everyone stay on mute, please? Thank you.
We're, as a direct support professional, we are responsible for helping a person with their health and safety, help with their growth, development, and all types of other skills. And because of that,
I'm sorry, someone is off mute. Could you please mute yourself out of respect for the speaker, please?
Thank you. And I won't be long, I'm almost done. It's definitely not from a clinical standpoint, but from experience. And when we look at mental health challenges from the provider, especially as a direct support professional, we have to realize that burnout is the most common challenge for almost every DSP, right? So we look at, okay, how can we cope with burnout, which shows itself as emotional exhaustion. You become numb, and sometimes you end up with health concerns, right? So some of the ways that we can assist our DSPs with coping. We can encourage them to seek support with one another, form a support group with each other where they're collaborating. And it doesn't necessarily have to be only within their agency. While this is a large field, it's also a small community. And a lot of us know people who work with other agencies, but just come together and bounce some ideas off of each other or vent, whatever it takes to help cope. That's benefiting mental health. Relaxing activities, you can meditate, color. There are adult coloring books, which for myself, I've had found very relaxing. And sometimes when we do it with our person served, it's a good bonding moment as well. And remember, a lot of people come in and out of their lives. So while they're giving us a lot that we must receive, they're also receiving a lot of changes. The doctors always tell us to exercise and get sleep. One of the things I think we also have to remind staff to do is to eat. So often when you're working and you're so focused on making sure your person is okay, that you forget about yourself. So as a DSP, we have to encourage them to remember themselves. And sometimes we got to just dig a little bit deeper. And a term I like to use is called gut check. So sometimes we have to look at, well, if I'm burnt out, what's the cause of my burnout? Is it just working? Or am I harboring any resentments that I feel towards what I have to do? Am I working overtime so much that I'm not spending the time with my family I want? Or am I just tired because emotional exhaustion makes our body tired? You know, we just take those times to just look at what's causing these negative feelings. Is it the field? Is it the person? Or is it just tiredness? And if that's the case, get some rest. Another thing I'd like to encourage people to do, and I have to do it for myself periodically as well, is make sure I find again my passion and my work. For me, I'm passionate about this field. I absolutely love it. Can't imagine another field I would prefer to be in. But we have to definitely find our passion, because it's easy to look at what's wrong, but we also must find a solution. And sometimes finding that passion can be a solution. You may enjoy basketball. Take your person and play basketball. This is a field where you can find joy in what you're doing. Now, that's from a DSP standpoint. As a supervisor, and of course, yes, we have a lot on our plates, but there are things that we can do to assist, to pull some of the pressure off. To me, and what I've noticed, one of the most important things is to observe your staff for signs of stress. Because sometimes we can step in, and I've done it, and say, hey, take a few minutes, I have this. Let me take this person, take a walk, take a breather, whatever it is you need to do. Because they have outside stressors that come in and can affect how they work. And it also helps to eliminate and prevent abuse, neglect, because their staff is exhausted and stressed out. But as a supervisor, we can jump in. I have no issues with doing DSP duties for some time, for the day. We can also present our staff with random acts of appreciation. We can bring a meal. My staff enjoys salmon. They love fish. And to just randomly bring a meal into work, it makes their day. Small tokens of appreciation, little bracelets, cute ink pens, just something to say, I thought of you. Remembering birthdays. Every month, we celebrate staff birthdays to make sure that they know that they are as important as our persons that we serve. We have to make sure that they're aware. And sometimes we have to create events to give them downtime. You know, again, the potluck, that gives them a downtime. We're fellowshipping together, and we're creating a unit and a bond. I also participate with community outings, and when I do, I also assist. Again, that's another bonding time, and it relieves a little stress because unfortunately, we can create a scenario where it's us and them, and we're not all on one accord. And when we're on one accord, we can work better and accomplish more. And our person see it and they feel it. And it gives them the opportunity to feel that they belong as well. So it's a well-rounded circle that's constantly going around. Also having family fun days. We'll go to the park. Everyone can invite their families. We're grilling and just enjoying each other. One of the things we also do since we've reopened is we created a mental health day. So once per month, each staff has a day off with pay. You're not using leave. You don't have to take off. You can stay home, rest. You can create your doctor's appointments, but to know that we care about your mental capacity to the point that you're receiving a day off with pay to do whatever it is that you want to do. And it's every single month. That averages out to 12 months per year, which is more than what you get when you accumulate leave, which is pretty much 7 days per week. But just finding ways to show that we care, we understand, and we're all together as one team. So that's my take on assisting with mental health from a provider standpoint, non-clinical. Thank you.
Thank you very much for that. And I would like to see if there are any questions or comments relative to what Dr. Smith has shared with us. There's a thank you, Charlene, from Allison. Thank you, Dr. Smith. Thank you for sharing. Great presentation. And also, I was to say there was also, and I didn't share this great presentation from Ms. Barnes as well as great presentation from Ms. Higgins after they finished. I forgot to share that. Thank you for sharing. Let's see what else we had. All right, looks good. I want to thank all of our presenters and everyone who attended today. This has really been very informative, and we have some takeaways as well as needs to follow up. More thank you, thank you, thank you. I would just like to say I hope everyone has a pleasant weekend, and it's the Memorial Day holiday. Hopefully, you know, you can take some time and rejuvenate and do what you know helps you in relative to Mental Health Awareness Month. And I just, you know, would like to just say have a great weekend, folks. We can end now. And again, I put my contact information in the chat. If anyone has any follow-up to this meeting, we'll do our best to ensure that we can help you in any way we can. So with that being said, I'd like to thank our interpreters as well as our facilitator, Charlisa Payne, and others who supported this effort, performance management and others, and the operations team. Thank you guys. Bye.